Assalamu alaikum, everyone. My name is Dr. Asghar. I'm working as an oncologist here in Kiran Hospital, Karachi. I'm sorry I had to come over there, but due to some official assignment, I have to stay here in Karachi. So I'm sending this my presentation and hope so it will be replaced by this my absence. This is a topic of radioactive iodine therapy resistant cases. When you start with your treatment with surgery followed by iodine therapy, and a time will come when the iodine is not so responding to your patient, their TG is getting high, and there is a lesion present over there which is usually not resectable also. So things are not comfortable at that time. So patient comes to you again and again that my TG is going high or anti-TG is going high, but my PET scan is coming negative. Usually PET is not required at that time, but if anyone go for this PET scan, they say PET scan showing some avidity, but no as such lesion, like the lesion is in something in the mediastinum, node at the subcarinal level, or there is lesion in the liver segment, or there is some lung deposit, or some deposits in the bones which are not resectable. Then what to do? Then the role of this tyrosine kinase inhibitor or multi-kinase inhibitor starts. There are multiple trials and that we can start with this different TKI treatment. And in the TKI treatment, we have the different, we have list of drug. I'll show you all these things. but initially, I will try to explain what are these different TKI, how it helps, and which TKI to be selected at what time. So you know from the basic of your knowledge of this DTC differential thyroid cancer, we treat with the patient with a surgery, followed by iodine therapy, and hormone replacement is being given at that time. Now, if there is some progression, then the role of EBRT, like external beam radiation therapy, surgery, or chemo is very limited. So chemo is almost no role. Surgery, yes, if it is resectable, it should be done. EBRT also, when even this TK is also not responding, or this patient is having some pain, like in the form of lesion in the bone, having severe pain, you can go for the EBRT also. So these have limited option, but we have a very good option in the form of different TKI. I'll show you. First, I'll try to explain the basic mechanism. You know, there are many transporters in the cell surface cell membrane, and one is the sodium iodide transporter. When two molecules of sodium go into the cell, it takes with one iodine also. So this sodium iodide importer is very important in the cases of this year iodine therapy. When there is problem with this importer, like in the case of resistant to iodine therapy, then definitely cell is not going to take up your iodine, and patients showing have iodine resistance, or you can say it has become a tennis. Like tennis is the TG is going high, but iodine is not showing any uptake of the scan. So this is the basics of thyroid follicle. The iodine, sodium iodine, when taken to the cell, it through the thyroid globulin releases this different mechanism of action and makes a T4, and T4 is coming into the circulation. This is the normal anatomy and physiology of this thyroid follicle. But what happened? In the clinical study, they have seen almost 20 to 25% of the metastatic thyroid disease lose their ability to take up the iodine uptake. So you can say almost all differentiated thyroid cancer may convert into radioactive refractory disease most of the time, and this ratio is roughly 20 to 25%. But when to treat them, it all depends. It doesn't mean if patients having the sub-centimeter lymph node in the mediastinum not showing any uptake on this iodine scan, and TG is also borderline going up, high up, so it's not an indication to start with the TKI. But yes, if the tumor is also progressing inside, if that node or any metastatic lesion is also progressing inside, roughly around 20% per year, then definitely it's a something refractory disease. We have to take some action. So almost 20 to 25% of the patients with the metastatic thyroid disease convert into radioactive iodine uptake resistant disease. So then we have to take some treatment like in the form of TKI. If you just see the survival benefit, if patients are iodine avid, you have a survival of 10 years survival of roughly 60% plus. But if these patients are not showing iodine avidity, 10 years survival goes down to roughly 10 to 20%. So it's a big difference of iodine uptake and no uptake. Until unless patient showing iodine avidity, this is the candidate to start with the continue with iodine therapy. Whatsoever the total average or final dose of iodine you can give. Some say 1,000 millicurie is sufficient. Some say may go up. So it's you are the best expert of all this thing. You know it better than me. But when it's iodine avid, we'll recommend this patient should be given iodine therapy. When not iodine avid, then definitely we can switch to different other regimes. I was just showing these slides. In our oncology, we are now working on we are playing on the basis of the genetic mutation. Whenever there's some genetic mutation, we try to treat the patient according to that mutation. If you just see the highest mutation which has ever been seen is in this just is a gastrointestinal stomach tumor you will see in the stomach, highest mutation, and we have level 1 evidence and we have the drug against this level this mutation. Second most common tumor which showing some mutation is the thyroid cancer. Like in the medullary thyroid, we have 80 to 90% cases of the RAT mutation. So in this same way, we have the mainly BRAF mutation in the case of differential thyroid cancer. So these are the mutations which can guide us to how to treat them further when the patient is not showing your iodine therapy, showing up response to the iodine therapy. Then we have the multiple options in the case of breast carcinoma. We have the multiple options in the case of melanoma. If you see, this green is the level 1 evidence. Level 1 means we have some FDA approved drugs against these medicines. Like this, we have many drugs, but in thyroid cancer, we have the level 2B evidence against the mutation, because these are the patients having some drug may not be having so much good response as you see in the case of GIST, as you see in the case of the different regime, other gene. And if you go for your basic physiology of this your immunity, we have the innate immunity, which is our itself by default. We have the innate immunity and we have the adaptive immunity. Adaptive immunity is that which you get due to some infection or due to some different antigen. And the main role of in this adaptive immunity is this your B cell and the T cell. T cell releases CD4 and CD8, and here these are the antibodies. So we're playing on the basis of these immunities also. We have the many monoclonal antibodies which can help us in treating the patient when there is some resistance to your antibodies in this iodine therapy. So in the innate immunity is the immediate response. Adaptive, it takes time. It's basically through the memories. It goes into the memory itself, but it's not taken to the memory. It's antigen non-specific and it's antigen specific. Same way, this is a different way when there is some antigen attack on this your T cell. CD8 has its own capability to take the action and kill the tumor cell. But in CD4, it takes the help of T helper cell. Helper cell activates the B cell, and then B cell releases the different antibodies, and which can help us in the treating the cancer patient. This is the mechanism of cell taken up there. Like if there is some antigen releasing, antigen is taken by the APC. APC is antigen presenting cell. These APC that releases different cytokines like T cells, and these are called the circulating T cell. When the tumor is showing more circulating T cell in their inside, they are more responsive to this your treatment. So CTL is another good marker to check whether this patient will respond to your immunotherapy or not. This is the same way. If you just say this is a TKI, basically stops phosphorylation inside the cell. But if there is some receptor like different PD-L1 receptor on this, if you're going to block them from outside cell membrane, then it can also inhibit the cell proliferation. When the activation of any pathway, like there's a different pathway like MAP pathway, RAS pathway, BRAF pathway. When the activation of any pathway, their tumor will show progression. And we have many drugs against that, like lenvatinib, we have cabozantinib, we have vandatinib. We have a list of drugs which can block these different pathways. And if you see on efficacy wise, we have the different drugs, and if show highest efficacy, then towards this is less efficacy. And we have the drug which have good response to the iodine refractory patient like lenvatinib, sorafenib, vandatinib, cabozantinib. These are all the different drugs which are fortunately available also in Pakistan, and we are using it, and they are showing very good response in this case. So what are the different indication when there is RD refractory disease? One, we have to check what is the size of this metastatic lesion or lesion which is not responding to your iodine therapy. It should be around 1 to 2 centimeter plaque size. Tumor should be progressing with 20% increase in the tumor size per year. If not progressing so rapidly, we can just wait. We can, this should also be a lesion which is not surgically resectable or is not a good candidate to be treated like EBR. Like if the lesion is in the lung and you are planning for the radiation therapy, so lung toxicity will be there, so preferable not to go. Surgically resectable if the lesion is, let's see, in the segment 4A in the liver, or some lesion is in the hilar region of the lung, so it's also not surgically resectable disease, or any node in the mediastinum roughly at the N2 level, then definitely these are the lesions which are not surgically resectable, so we have to treat them then with some different TKIs. If you just see the TKI response, the highest response against the different your receptors we have seen with the sorafenib, we have seen with the lenvatinib. This lenvatinib blocks the VEGF receptor also. Lenvatinib blocks the PDFR receptor also, KIT receptor, RAT mutation, and all these different. Another good drug, if in choice, if you just ask me, this drug is showing very good response, I'll show the trial. Then the sorafenib, then we have option of this cabozantinib, then we have options vandatinib. Vandatinib come with the name of Caprelsa, cabozantinib come with the name of Comitrax. So these are all these drugs fortunately available in Pakistan, and we are using them. But when a patient referred to us for TK therapy, our first choice is start with the lenvatinib on the basis of this trial. So the SELECT trial, these were the patients who were iodine refractory, 392 patients who were iodine refractory, and they have the measurable disease, and they have taken one prior VEGF receptor therapy like in the form of sorafenib, and they were given the lenvatinib. Lenvatinib dose is highest in the case of CA thyroid, like 24 milligram per day, while in the case of hepatocellular carcinoma, we usually give 8 milligram or 12 milligram. And when they compared this lenvatinib with the placebo, and they saw a miracle responsive, like there is a progression of survival of 3 versus 18 months. So it's a big difference between the lenvatinib and the placebo. So this look, and it's quite easily taken up the disease because it has less side effects, except this patient, the patient on the lenvatinib may have the hypertension issue. But patient with known hypertension is not a contraindication to start with the lenvatinib. We can start with the lenvatinib, but we have to take care of their hypertension. But as compared to the sorafenib, which is having the very extensive skin reaction on the hands and foot, so we have to we see very rare side effects of skin reaction with this lenvatinib. This is a famous trial about the sorafenib. This was the CN trial. They have treated the patient upfront with the sorafenib 400 milligram BD dose versus placebo, and they saw the difference of 10 versus 5 months. So initially we used to start this Nexavar and this sorafenib, but now after the availability of this lenvatinib, so we have switched towards that. But if this patient, definitely the lenvatinib is somewhat expensive. If this patient is not affording, then we can start with this sorafenib, and it's easily available. This is also cheaper now. And we just see the response rate. There's a good response with this sorafenib as compared to this placebo. If you just ask me the comparison, yes, definitely. There was a difference of 10 versus 18 months in the drug arm versus placebo arm 5 versus 3.6 months. So if you just see over here, hypertension was 44% in the cases of this lenvatinib. And diarrhea was somewhat same, but this palmar plantar erythema, which was 19% in the case of sorafenib, it was just only 3% in the case of lenvatinib. So we can safely start with both of any of these two medicines, preferably this one, but if financial issue, then you can start with this one. But what to do when there is a progression on any of these two drugs or both of these drugs? Then what to do? Then we have option of this cabozantinib. Before cabozantinib, there was another drug which is a vandatinib with the name of Caprelsa. This was a phase 2 trial, and they also saw some difference over here. But the ideal drug, which is a phase 3 trial, this was a COMIC trial, cosmic trial. The cosmic trial show the different, use this cabozantinib 60 milligram daily, and all these patients have either taken this sorafenib or have taken this lenvatinib, and now they were started with this cabozantinib. And if you see, there was a response rate of 11 months versus 1.9 months in the placebo group. All these patients have taken this either sorafenib, lenvatinib, or both. So we have an option to start with the cabozantinib, and we have treated the patient with the cabozantinib, and we have seen a very good response.